Welcome to the podcast where we discuss health, health span, lifespan, and longevity. I'm Dr. Noor Gajraj. Welcome to the podcast. Well, today we have a very special guest, Attilio Cavezzi, MD. He's a specialist in vascular surgery and an expert in longevity medicine. He is medical director of Eurocenter Vena Linfa in San Benedetto del Tronto, Italy. He is the past vice president of the International Union of Phlebology. He has received many awards. He's the author of more than 100 publications about vascular diseases, longevity medicine, psychoneurobiology, and hormesis. So thanks very much, Dr. Cavezzi. Perhaps to begin with, you can tell us a little bit about yourself and how you got into the field of longevity.
Well, North, first of all, thanks a lot for your kind invitation, really. Then, I am a vascular surgeon and I am especially dedicated to vein and lymphatic diseases. And I take care, of course, also of the arterial diseases, but only from the diagnostic and medical point of view nowadays. Having said this, I became more and more interested in longevity medicine because, first of all, because of my personal issues, let's say, but then I started to realize that probably it is really important to live longer and healthier, let's say. And to do that, you have to study a lot because as a vascular surgeon, I was taking care of all the vascular issues around our body, but I was not taking care, let's say, of thyroiditis or about diabetes so much or about obesity because there were specialists doing that. Then I realized that I had to do that for my patients. So if I wanted to take care of their legs, for example, I had to take care of their obesity, of their failure of pumps, of their drugs they were taking, let's say, for cardiovascular diseases or their autoimmune disease. So basically, I realized that I had to improve the knowledge of the chronic degenerative diseases. And that's why I was talking about basically aging, because aging is the disease, let's say. And I'm convinced that longevity medicine is probably destined to become the most important medical branch in the next future.
Excellent. All right. So you're going to give us a presentation. Thanks for that. It's going to be a slide presentation.
Okay, so I will present a number of slides just to start to highlight how our current medical approach to chronic degenerative disease and to aging more in general should be somehow, let's say, reviewed, should be changed, to make it simple. This is my disclosure slide. There are no special commercial interests. So we should be somehow humble since the very beginning, because science is a constantly changing base of knowledge. This is something I always keep in mind. And starting from this simple slide where long time ago Ansel Keys was somehow destroying the saturated fats and so was promoting his own culture of and the myth of cholesterol. We know that this was probably wrong since the very beginning, his research, and nowadays, or let's say since 2014, in this case, in the Time cover, we know that we should eat butter, just the opposite of what he was saying at that time. This is a kind of admission of the need to be humble when we talk about science. Having said this, we have to have a look at what's happening in medical bioscience. Why? Because in the last 100 years, what we have done is to prolong the average lifespan. That's sure. So we live longer. But unfortunately, we do not live healthier. So we have not prolonged the average health span because on one side, the maximum age has always remained the same. I mean, around 120 years or whatever. But the price we are paying nowadays to live longer is a huge increase of the chronic degenerative diseases. So diabetes, obesity, neurodegenerative diseases, cancer, atherosclerosis, autoimmune disease, and so on. And the vast majority of our elderly people are disabled somehow, and they depend, our aged people depend predominantly on drugs and biotechnology. So this means we are increasing the age, not improving the health for our elderly people. If we think about aging and chronic degenerative disease, since the very beginning, we have to highlight how epigenetics is important because we know that nutrition, lifestyle, stress management, which means also the importance of mind, the importance of resilience, and environment are the main factors which affect our health and our disease onset and progression. So much more than genetics, 75% was somehow calculated through a few articles. 75% of our diseases, of our aging, is in our own hands. It depends on how we live. This is very important. This is just epigenetic. That's why I like this sentence. We are born as copies, but we die as originals. So, what is epigenetics? Nutrition, lifestyle, stress management, and environment. To make it simple, let's say. So, how we eat will influence dramatically our health or disease state. Lifestyle means not only smoking, alcohol intake, and so on, but also physical activity, sunlight exposure, sleep, which is very important, and all the psychosocial factors. Stress management, which in my humble opinion is the core issue of human health. So all the possible physical resilience issue to take care, and then the environment. So, to make it simple, all this stuff is not so well taken by the current medical approach, which is mostly based on drugs, medications, technologies, and not on the correction or the improvement of these very, very important epigenetic factors. So, as a vascular surgeon, I started to highlight in a few articles this one, for example, this one, and another one, for example, how it is time to change. We need to change the current, the usual medical approach to our patient. Why? Because somehow even artificial intelligence tells us, this is a kind of summary of what artificial intelligence replied me when I asked about chronic degenerative disease. We cannot definitely cure these diseases. We just cure symptoms and we take care of the quality of life, which means that we are missing something. Why can we cure these patients? Because we do not fully understand these diseases. And this is a tragical reply from the artificial intelligence, but this is true. So, in conclusion, as you can read here, modern medicine gives us some tools to manage chronic degenerative disease, and we improve quality of life and we try to slow disease progression. But we are not able to take care of neurodegeneration, of autoimmune disease, cardiovascular, atherosclerosis, and so on and so on and so on. Now let's start the critical part, let's say. Who is John Ioannidis? He is very famous in USA because he is a very famous epidemiologist, also during COVID pandemics and so on and so on. So this article is the most read and cited article in the whole public library of science.
Well,
And he clearly demonstrated through a very, very careful literature review that unfortunately most published research findings are false. And this is due to a lot of biases, a lot of errors, a lot of problems that researchers or doctors or bioscientists may encounter during their work or whatever. And especially, as you can read here, the greater the financial and other interests and prejudices, the higher the possibility to have a bias in the medical literature that we are reading. Later than that article, more recently, let's say, again, Ioannidis with many other doctors reviewed Cochrane reviews. So we know that Cochrane reviews are very important for our medical practice. And what they found, investigating 1,567 interventions, they found that mostly they were of very low quality evidence. So what we do in medicine is a very low quality evidence. And the conclusions of this article is a little bit, let's say, disappointing. More than 9 out of 10 healthcare interventions lack high quality evidence supporting their efficacy and safety. So this is something to keep in mind. This is an article which was published in the British Medical Journal as a kind of a supplement. And you can see that when we look at what we do as doctors, they investigated 3,000 currently applied treatments. Again, 50% of the things we do as doctor were rated of unknown effectiveness. So it means that we work, but we have no evidence that we are doing always good, and especially we are doing no harm at all, because you can see from these percentages here that there may be harms, there may be ineffective, and so on and so on and so on. This is another article, for example, another article even more recent, where they investigated several groups of drugs. And again, 13 drug groups had a very low efficacy level, or they resulted non-effective from the literature analysis. And in terms of prolonging life, only one proved effective, which is metformin. Even metformin could be questioned, but that's another story. This is an article, this one on the top, which I wrote with a few colleagues. And just to make it clear, we are somehow interested also in the question of conflict of interest. Because, for example, we highlighted how the document of the European Society of Cardiology on lipid lowering drugs included 66 pages where all conflicts of interest were declared. So you can imagine it's a huge amount of conflict of interest on the basis of this European document, consensus document, and so on. And this problem of the conflict of interest and the outcomes of cardiovascular trials has been raised many more times, for example, in the article here below. When we go, for example, to the referee, so the method we use to assess an article when it is submitted to the journal. Here, the researchers investigated a few, the major, let's say the major medical journals, and what they found that more than $1 billion was spent to pay the reviewers, not for the article, of course, but that means that the reviewers of these very important journals are strictly linked to the companies somehow because they receive some funding for their research or whatever.
Mhm.
If we move, for example, to FDA approved drugs, this is a survey which was performed by Harvard University researchers. What they found was that 73% of the FDA approved drugs do not meet the basic requirement to demonstrate the evidence of efficacy. And you can see here the list which are these requirements. So 73% of the FDA approved drugs and half of the studies required for FDA approval have never completed a follow-up, but the drugs remain on the market. So this is something which sounds strange to me. You use drugs which have not completed the FDA approval studies. So this is something to keep in mind. When we move to oncology drugs, only 3 of the 123 approved drugs by FDA for oncology had met the 4 criteria that I presented before. The vast majority of these medications for cancer were approved just because they reduce tumor mass, having no effect on the survival rate or on the quality of life. Again, another study in 2015 found that 87% of the anti-cancer drugs approved by FDA were based on indirect results and there was no effect on life extension. So we are talking about drugs which have a huge impact also from the socio-economic point of view. You see here, for example, the issue of the medical reversal. So there are drugs in USA and worldwide, of course, that they may stay for 9 years on the market, and then suddenly there is a reversal or more than one reversal studies, and they have to retrieve the drugs from the market because they didn't work. And there are drugs that have been, let's say, reversed after 50 years even. So it's something, again, which should lead us to think about that. A few of the new, for example, drugs, medications for cancer are the monoclonal antibodies. And for example, in the case of this monoclonal antibody, in this systematic review and meta-analysis, they found that the risk of the fatal adverse events with this drug for cancer had a very high odds ratio, 2.3. And if you compare this treatment with, the, for example, ipilimumab with the placebo, the fatal adverse events were much higher in rate compared with the control arms. So we are using drugs which may have a lot of side effects. Last but not least, the cancer drug, the chemo drugs, cost 4,000 more than gold. And again, we need to pay attention to money because we all know that the health sanitary, the national health systems need a lot of money to go ahead. Then we can move also to the cardiovascular world, where again, this analysis of the randomized controlled trials, for example, published in 2017, we can see here that, to make it simple, two-thirds of the randomized controlled trials in the field of vascular disease were at high or unclear risk of bias. But this was highlighted a long time ago, as you can read from this very old article, which was published in 1994. So this is an issue. We publish articles on which we base our practice, but these articles have a high risk of bias. Another issue to keep in mind is the so-called disease mongering. There is a guy, the name is Henry Gadsden, who clearly stated that producing drugs for healthy people is an extremely interesting stuff because that would allow us to sell to anyone just like chewing gum. If you create a disease, you create a drug, you sell the drug. It is important to create the disease. What does it mean to create the disease? To have a code, to have the possibility to justify. And this has been clearly highlighted on several occasions. Also because, as we can read from the, let's say, clearly reported balance and so on, the contributions from pharmaceutical and health technology companies to FDA or to the European Medical Association amount to approximately 50 or 86% of the agency budget. So it means that these agencies, which regulate how, when, and if we can get this drug for this disease, are somehow dependent on this money. And this is again to keep in mind. There is a guy, the name is Peter Goetze, who is one of the greatest scientists in the world. He clearly demonstrated in terms of disease mongering and misuse and overdiagnosis, for example, that for mammography, there was no difference in mortality risk between screened and non-screened patients. It was clearly demonstrated. And furthermore, we know that the problem with mammography, as you can read here, can lead even mammography to health issues for the patient. That's why the Cochrane review highlighted that all the studies which were taken into consideration did not find, at the end of the day, did not find an effect of screening on total cancer mortality, including breast cancer, or on all-cause mortality. So, to make it simple, if you look at this, let's say, conclusion of the Cochrane review about mammography, for every 2,000 screened women, one over 10 years, one will avoid dying from breast cancer thanks to mammography, and 10 healthy women will be treated unnecessarily. This means also that 200 out of the 2,000 women will have problems, psychological problems, distress, because mammography gives us false positives. So, all this stuff to clearly highlight that overdiagnosis is also another problem. In terms of disease mongering, we should talk about, for example, fibromyalgia. I think this is the English, I don't know, fibromyalgia. This is a syndrome. This is not a real disease. We don't know the cause, and there are several symptoms which are involved, and they vary from person to person. So when we talk about symptoms, we shouldn't talk about a disease. These are people who feel pain in their muscle, in their tendons, or whatever. But there is no a definitely identified cause. That's why fibromyalgia has been clearly questioned several times in medical literature in terms of being a real disease. Because you see the symptoms: fatigue, sleep disturbances, cognitive problems, mood disturbances. They are so specific that it is real difficult to think about one single disease. And the same could be said about the attention deficit, the ADHD, to make it simple. Okay. Does it exist? Does it exist? From these articles, for example, it has been concluded that the diagnosis of ADHD must unfortunately remain dependent on the interpretation of the doctor of those symptoms that our patient refer. Probably the child, because this is mostly a child disease, probably the child has had some psychoneurobiological problems during the first 1,000 days of life. This is another story, okay? And that's why we should think about how we spend for a code for a disease which has in fact been questioned, because we know that in USA 22 more billions are spent in drugs for ADHD only. This is a huge amount of money for a disease which could not exist. Now, all this stuff is leading authors, and this is an article which was published in 2000, to say that basically, if cardiovascular disease is the first cause of death and the cancer is the second cause of death, the third leading cause of death in the USA, and I would say worldwide, is just the doctor. It's just the medical approach as we imagine this. But this was an old article. How is this the situation nowadays? This is from the British Medical Journal, exactly the same. They calculated and calculated, and they had to admit that the third leading cause of death is medicine. Medical error, medical overdiagnosis, medical overtreatment, and so on. Even more recently, even again, Peter Goetze, the great Danish, he was responsible for Cochrane. Then he went away when he saw that something was not so good. But okay, Peter Goetze started to calculate step by step a lot of which can be attributed to medical errors, to side effects of therapies, to misdiagnosis. And you can see here somehow 400,000 deaths per year can be due to medical issues and not to diseases. That's why his calculation in this wonderful article was that nearly 900,000 drug-related deaths are present in the United States annually. This is a huge amount of people who can die, or let's say who die because of a medical issue. Let's call it issue. This is a very careful calculation he did. So we should think what is primum non nocere. This is the basic principle which we as doctors should keep in mind anytime we work. First, do no harm. So we should think and rethink before deciding a diagnostic procedure and especially therapeutic approach. For example, let's start with the other kinds of drugs, the lipid lowering drugs. First of all, what is atherosclerosis? To make it simple, I tried to summarize here. It's a matter of nutrition, but especially it is a matter, as we will see, of excess of insulin. It's a matter of wrong lifestyle, such as smoking, impaired sleep, sedentary lifestyle, and so on. But especially, it is a matter of stress. There is more and more evidence of the linkage between atherosclerosis and stress management, which gives a hyperactivation of the stress axis and gives a hyperinflammatory state in the body, which is the root, the chronic low inflammation in the cells, let's say. And more recently, for example, it has been discovered that lipopolysaccharides is also a very relevant issue in terms of atherosclerosis onset and progression. So you see in this slide of mine, there is no place for cholesterol as we think. As we will see, it's not a matter of cholesterol. But it's not me telling this or writing this. There was a study which, in my humble opinion, was simply fantastic, the Pure study. This is a great study which united 18 countries from 5 continents. And this study was published under several formats, let's say, and they concluded that the role of the saturated fats is completely exaggerated for atherosclerosis. On the contrary, the high carbohydrate intake was found associated with a higher mortality, whereas the higher fat intake was associated with lower mortality. So it's completely the opposite we were told, and we are probably still told today. And that's not only a question of pure study. More and more studies are published highlighting how cholesterol is not linked as a pure assassin, let's say, to the development and the progression of atherosclerosis. I couldn't go through all the literature because we have probably more than 100 high level articles about this stuff that cholesterol is not interesting. To make it simple, this is a very recent article which was published in the New England Journal of Medicine, not let's say a small journal, okay? New England Journal of Medicine. And they basically clearly stated that the risk factors, especially for all-cause mortality, is not cholesterol, is not a matter of fat. On the contrary, it's a matter of obesity, smoking, and especially diabetes. When we look at the curves, you see that especially diabetes is the main factor affecting the risk for atherosclerosis. Here is a small study, but very interesting, which was recently, very recently published. You see, they investigated 106 years. And what did they find? They found that the survival time was longer in those elderly people who had the higher level of LDL. And the hazard ratio is incredibly significant. Is incredibly significant. The higher the level of LDL, let's say the longer the lifespan, to make it simple. The higher the LDL, the better the health. This is a systematic review, so high level of evidence. What did they found? That there is an inverse association between all-cause mortality and LDL level. Inverse association. So basically, higher level of LDL were found inversely associated with mortality in the vast majority of the people over the age of 60. This is a systematic review. Doctors still think that we must lower LDL level to live longer. It's just the opposite. Below 100, you live shorter. And many more articles. Total cholesterol was not found as the cause of cardiovascular disease. Again, the higher, as you see in this article, for example, the higher the cholesterol LDL level, the greater, the better the longevity. Now we come to a fundamental issue, in my humble opinion. cholesterol is a big basket where we find everything, okay? There is one part of cholesterol which is atherogenic, which creates atherosclerosis. That's the oxidized LDL. That's the small and dense LDL. A tiny fraction of cholesterol is the one which is responsible for atherosclerosis, not cholesterol. That's why it's a nonsense to combat cholesterol as a whole, let's say. And if you look at these studies, for example, they investigated those patients which were hospitalized for myocardial infarction. Again, those who had a lower level of LDL had a higher risk during their in-hospital stay, higher risk of mortality when they had the lowest LDL quartile. On the contrary, for example, higher level of LDL gave a lower risk of mortality. In this second study, they call it lipid paradox because it's a kind of paradox as to the conventional medicine. Again, when the LDL was below 62.5, it was a predictive factor of higher 30-day mortality in the hospital after acute myocardial infarction. So you see, again, we have to understand what is atherosclerosis before giving drugs only on the basis of wrong, probably literature or misunderstood finding, let's say. This article was published, I think, 2 months ago. Was published by Dutch researchers, and this is their conclusion. So, to make it simple, there is no linear association between LDL and risk of CVD, cardiovascular disease. LDL is a pure predictor of CVD risk. Lifelong elevated LDL may result in long CVD-free lives. So the higher the level of LDL, the longer the life in cardiovascular disease patients. Exactly the opposite of what we are told or what we were believing, because I'm not believing in this anymore. I started to change everything, let's say 12, 13 years ago, but it is important to reiterate this issue. So, which are the drugs that we use? Well, we use statins, first of all, we use ezetimibe, PCSK9 inhibitors, and so on and so on. What do? They harm anyway our body. Because if we use a drug which has no effect on mortality and no effect on the health, could be even acceptable. But these drugs create problems to our health. Why? First of all, because they reduce mitochondria activity, mitochondria functionality, because the enzyme which they attack, especially statin, is the same enzyme which will produce, for example, coenzyme Q10, vitamin K2, and so on. And even more interestingly, very recently, it was discovered that statins inhibit glucagon-like peptide 1, which is so popular now. We will discuss about that in a while. So statins favor diabetes, favor obesity, and so on and so on. This is a very reliable website. In this website, the NNT website, they examine medical literature month by month, and they highlight the evidence. So basically, they say that statins should be given only for 5 years for heart disease prevention, and the rest would have no meaning. Again, even conventional website, conventional agencies start to understand more. Now we move to the literature concerning especially statins. This is a systematic review again and a meta-analysis, so an extremely high level of evidence-based medicine, okay? This is important to highlight, to underline this issue. They investigated 60 randomized controlled trials concerning statins, ezetimibe, more than 300 patients included in these studies. Intensive LDL lowering is not association with any reduction in all-cause mortality or in cardiovascular mortality. Full stop. If you give statins, if you don't give statins, things don't change. What changed? LDL level. That changed, but it doesn't work for cardiovascular mortality or for overall all-cause mortality. That was meta-analysis, systematic review. Another systematic review, another meta-analysis, 21 statin trials, meta-regression did not demonstrate any relationship consistent, let's say, between LDL lowering with statins and death and heart attack and stroke. We are talking about, you see here, absolute risk reduction which are negligible. Basically, the absolute risk reduction is nearly zero, below 1% in the vast majority of the cases. Now we should take into consideration those three trials which were fundamental to give green light to the, let's say, use of statins in atherosclerotic patients, in cardiovascular disease, and so on. These are very important articles, very important studies. And these are all industry-sponsored trials, and they all the times they demonstrated that LDL values was reduced, of course, and there was a slight improvement, 1% on average, in the absolute risk of major cardiovascular events. But there was a significantly increased risk of mortality in the treated patient. Maybe you reduce by 0.5% the cardiovascular risk, but you increase the mortality risk. This was demonstrated in the industry-sponsored trials. No one took care of that. So we want to reduce the cardiovascular mortality, true or false, whatever, but we cannot improve the general mortality. We do the opposite. And now I want to stress this point. This is probably the most important issue to keep in mind, the difference between absolute and relative risk. The Ascot study, for example, on atorvastatin was fundamental again to explain how this statin works in cardiovascular patients. Well, what did they find in this study? They found a relative 36% reduction in the relative risk, okay? 36. So it is a huge number. 36% of our patients will reduce the cardiovascular risk, okay, of the heart attack, let's say. But very, very small in the advertisement, you can read that the patients who took atorvastatin had a 1% risk of heart attack. The patient who took placebo had a 2% risk of heart attack. It means that the absolute risk in this industry-sponsored study, the reduction in the absolute risk was 1%, not 36%. 36 is a kind of trick. And the problem is that if you look at these statements here on the left, the relative risk to be statistically significant should be around 100, 200, 300%. Below those figures is a nonsense. So this reduction in the relative risk in this study was absolutely a nonsense from the statistical point of view. It's not my affirmation. It's not my statement. These are statements from high-level people, National Cancer Institute, Dr. Angel, she was editor of the New England Journal of Medicine, Temple, which was the director of drug evaluation at the USA FDA. So they clearly state below 100, 200%, it's not working. But based on this study, atorvastatin invaded the world. As you can see, for example, from this study, from this meta-analysis, for example, statins do reduce LDL level, of course, but 62 to 75% of the patients in this meta-analysis still had the myocardial infarction, notwithstanding the LDL reduction, with or without that during the study. So the study was okay from the LDL point of view. Now let's have a look at their safety. Statins do beyond decrease the transaminases, they increase the CPK, and they increase diabetes, and you see the hazard risk is very high. So they increase the diabetes with a hazard risk of 1.46. So there is a 46% increased risk of diabetes, rheumatoid arthritis, cataract, hemorrhage, stroke. Literature is full of statin adverse events. And now let's talk about statin and cancer. I will present three studies now where the authors investigated, for example, pravastatin or placebo in more than 4,000 patients. What did they find? They found the usual issue of the cardiovascular benefit, true or false, whatever. But then they discovered that the patients who took pravastatin had a relative risk of cancer increased by 809% cancer. What's their explanation? This could be an anomaly due to the low number of total events. Other two trials, the Prosper trial and the SARE study, they found, to make it simple, very similar findings. Cancer incidence was much higher in patients undergoing statin treatment. And in both articles, they say that it's a chance finding in the first article. And in the second article, you see this is the different 11.1 in the treated patients, 11.1%, and 7.5% in non-treated patients. And they say it was not associated with an increased risk of cancer, and the observed difference may be due to chance. I think it's not very fair to say that cancer incidence is higher in statin patients by chance. It's not very fair. I'm sorry if I am too crude, probably. And statins, we know that, especially if they are lipophilic, they can give cognitive dysfunction, they give neuropathy. And more articles are highlighting the ugly side of statins. And especially, I would say that nowadays awareness is growing on this type of drugs, the lipid lowering drugs. Now we move to another group of medications which can be really a problem in terms of health, the proton pump inhibitors. The proton pump inhibitors were created to combat, to heal acute problems in the gastrointestinal tract and so on and so on. But then, after some time, let's say, they were quietly switched to chronic therapy. And that means that this kind of drug, of course, interacts with the absorption because you dramatically change the pH in the gastroduodenal tract. So you change the micronutrient absorption, which means hypochlorhydria, which creates dysbiosis, and the microbiota dramatically shifts to a pathogenic flora, to a pathogenic kind of microbiota, which we know is so important for longevity because microbiota is strictly linked to a series of chronic degenerative diseases and to aging itself. Let's have a look at statistics again, because it is important to look at statistics. Exposure to proton pump inhibitors dramatically raises the risk of pancreatic cancer. This is the result of a meta-analysis article where they found that, as average, the pancreatic cancer had an odds ratio of 1.75, so 75% increased risk in patients who take proton pump inhibitors, risk of pancreatic cancer. And if you take rabeprazole, this risk was 445% increase, 5.40. So we can see that this is an issue to keep in mind. Dementia, asthma, so I will not go into details because I don't want to be too detailed in my presentation, but you see that proton pump inhibitors can give dementia and asthma, and esophageal adenocarcinoma. This is an incredible study. You see, nearly 800,000 Swedish adults, a study on 800,000 Swedish adults taking PPIs. The risk of occurrence of esophageal adenocarcinoma was 3.93. So patients undergoing for 7 years uh, PPI therapy have a much higher risk of esophageal adenocarcinoma. It is also true for osteoporosis. HR is 1.62. It is also true for diabetes. And now we have a look at the death risk. Patients which use PPIs, proton pump inhibitors, they have a higher risk of death compared to the very old and still efficient H2 blockers. You see, we are talking about a hazard risk of 1.25. So H2 blockers have a much, much lower risk, generally speaking, of death in comparison to PPI. This is another, these are two studies where they, for example, demonstrated that there was a 100% increased risk of cardiovascular mortality undergoing PPI treatment, which was not true for H2 blockers. So why should we use PPI treatment in a chronic way if we increase dramatically this risk? These are studies, this is a cohort study, systematic review, and meta analysis, so high level of evidence. What do they find? That mortality is higher in patients undergoing PPI again. You see, the hazard risk can be around 1.65, 1.38, even 1.96 compared to the users of H2 blockers. So mortality risks increases when you are under PPI, and patients should know it. Now I want to talk about a couple of simple, let's say, molecules which must be known in depth. Folic acid is so common, at least in Italy, because of heterozygosis in MTHFR, which is so common, at least in Europe, around 45% of the population, and the hyperhomocystinemia. So you give folic acid, but pay attention to the fact that you need to supplement the patient with the methylated folic acid, not with the simple folic acid, because that would mean an increase of unmetabolized folic acid, a decrease of B12, and a series of possible adverse effects from folic acid supplementation. So, low doses of methylated folic acid is the proper use of this molecule. And you see here so many articles which clearly demonstrated it. Vitamin D, which is so popular, so important for human health. It could be a problem if not properly supplemented. It is a kind of hormesis issue. I don't want to talk about hormesis at this point, but in case if you want, we can do later. Because toxicity of vitamin D intake is a dose-dependent one. So first of all, which dose? Because vitamin D alone can cause extra bone calcium deposition, which means deposition in the arteries, in the heart valves, on the renal parenchyma, in the brain, and also asthma can increase when you give high level of single vitamin D. So what we should do with vitamin D is to avoid mega doses, and we should supplement daily, not just once every 2 weeks or once a month with mega doses, because that doesn't work as to literature again. So more than intermittent high dose of vitamin D, which does not work, and you can see from this meta-analysis, for example, you should think about the supplementation on a daily basis. It is compulsory to join vitamin K2 to vitamin D, supplementing our patient. There is a huge literature which has clearly demonstrated that with vitamin K2, the extra bone deposition is much, much lower, if not absent. So it means that vitamin K2, menaquinone 7 especially, plus vitamin D is a very interesting and efficient and safe, especially supplementation for our patient. Now, the issue of opioids, the issue of psychotropic drugs. These drugs may kill more than Vietnam War, unfortunately. And you see, there is a continuously increasing use of these drugs in USA, a little bit less in Europe. But for example, in 2021, 54 million people were using over-the-counter prescription drugs for no medical reason regarding this problem of, let's say, psychotropic drugs and so on. So there is a continuous increase of prescription and of personal use of these drugs. And this is true, unfortunately, also for children. Can you imagine that 5% of the children who suffer from psychiatric disorders receive psychotropic medications? This is a real national tragedy in USA and starts to be also in Europe because 10-20% of the children worldwide suffer from psychiatric disorders. Now we are moving to the end of my presentation. Now we talk about a very on-fashion medication, the GLP-1 agonists. So we know that we can reduce weight, we can improve diabetes, and so on through these GLP-1 agonists. The most famous is semaglutide. When you give semaglutide to patients, the vast majority of the patients interrupt the intake of the semaglutide, as you can see from this study. And when they interrupt, they invariably regain weight. And this is an issue. But I would like to highlight this study. This is a fundamental company-sponsored study aimed at FDA approval of the semaglutide. So what did they highlight in their fundamental study? They highlighted that administering semaglutide, you get 96.1% of minor or serious adverse events, and 7.5% of the patients under semaglutide had serious adverse events. 8% of the patients who undergo semaglutide have serious adverse events. This is to be kept in mind. Also because a very recent data, this is from British Medical Journal 2025, you see that in USA there were nearly more than 80 deaths due to GLP-1 agonists. And last but not least, semaglutide is extreme, and let's say GLP-1 agonist is extremely dangerous, especially in terms of suicidal ideation. I mean, the wish of suicide increases dramatically in patients undergoing GLP-1 agonists. And in those patients who are already depressed and take antidepressant, they have calculated that this increase of the suicide ideation increases by 445%. When I look at these numbers, at these figures, I remain a little bit astonished. And I say, why don't we talk to our patients and explain what is diabetes, what is obesity, how to improve, instead of putting them at risk so much? Last but not least, to produce, for example, the semaglutide medication, you need from $1, let's say, to $5. This has been calculated in this study. So this is the cost. Can you imagine that the average cost in USA is around $350, $370? This disproportion is incredible because it means that the global market of the GLP-1 receptor agonist is increasing, and in 2024 it was $52 billion just in 1 year. And it is expected that in 2032, it will be $186 billion per year. So we are talking about something which may destroy the national health system. And we have a good news. We have good news because we have very low cost alternatives, which have discovered thanks to my collaborator Simone Camelli, who got a few experimental animal studies, but not only animal studies, because simple molecules such as the ursodeoxycholic acid, or even better, the allulose, which is let's say a variation of the fructose without any negative effect of the fructose, they cost nothing, they supplements, and they significantly increase the levels of glucagon-like peptide 1, enhancing glucose metabolism, appetite control, and so on and so on and so on. So let's keep in mind these alternatives as well. Now we move to the very last part. So it's time to change because there are biases. So I will not go into so many sentences here, but there are biases in what is medical literature, medical practice, medical education, and so on and so on. Could be cognitive biases or other biases. And these biases have been highlighted, not only in my presentation, of course, but been highlighted in several hundreds, thousands of publications. That's why the biomedical approach should somehow change. Some of the biases are linked to the industry, which have and want to fund most of the scientific research because there is a proliferation of industry-backed scientific studies, and we invariably find a discrepancy between the outcomes of the independent studies in comparison to the studies published with the industry-sponsored funding. So again, we have to keep in mind what means medical literature and corruption. Corruption is an issue. Several journals report the loss of money due to corruption in the medical management, books and articles. Industry sponsor education is not probably what we should have all the time, especially with young doctors. And we should not treat only symptoms and signs, and as we are doing in most cases. We should talk to our patient about the nutrition, lifestyle importance, psychosocial, chronic stress, which are on the contrary emphasized nowadays when in our current medical practice, because we overestimate the biochemistry, the genetic issues in the medical diseases, neglecting the epigenetic issues. So if we want to talk about the scientific progress, the real scientific progress should take into consideration all this stuff, also because the socioeconomic issue of the health expenditure is becoming so important. We are living longer. That means more money for health. That means that, again, we increase in patient disability, and there is a generalized time to abandon the reductionism, which typically features the current medical approach. It's time to focus on the several biases we have. Cost effectiveness is important because we know that just for example, obesity is so important and will cost more and more. So if we extend, as we are doing, the average life, and we do not extend the corresponding health span, we of course cause an exponentially increasing problem to our social economic system, hence to our civilization. So it's time to talk to the professionals, it's time to talk to the patients, it's time to talk to the industries, it's time to talk to the politicians. And our patients should not prefer pills and technology to the due changes in their lifestyle, nutrition, and psychosocial conditions, stress management. So doctors should retake this approach to talk to the patients and somehow lead them to their changes, due changes, to choose wisely what to do, not just based on drugs and technology, because otherwise we have an overuse of procedures and we threat the financial balance of our national health systems. So again, medical practice should be a transitive relationship between a truth of reason and a truth of fact. In among evidence, doctor, patient, we need this kind of centered approach if we want to improve medical approach from the socioeconomic point of view, from the efficacy point of view. And just to make it simple, we are completely neglecting the psychoneurobiology issue, which is the key issue for human health. When we look at all the possible factors which affect aging, which affect health span, which affect mortality, the key factor for longevity is resilience, stress, psychophysical stress tolerance. These articles are so clear. Mortality curve and the survival curve are strictly dependent on resilience of the patients, not on smoking, not on eating, not on moving, but on resilience. These are, for example, studies, and in this study, this is a very recent study, there was a lower mortality who had a higher resilience score through different, let's say, systems. To go to the last concept that I wanted to highlight, this was an article which dramatically impacted my mind. This is a meta-analysis of 165 articles. We think cancer is a matter of nutrition, maybe it's a matter of smoking, maybe it's a matter of unfortune, let's say, it's a matter of a casual matter, and so on and so on and so on. But in this article, it was demonstrated that cancer is a matter of resilience. Low resilience was significantly associated to a higher risk of cancer. And a similar hazard ratio was found for chronic stress. So if you don't want cancer, you have to improve your resilience much more than your diet, much more than your exercising or whatever. This is a wonderful study about myocardial ischemia stroke. And again, optimism significantly impacted the relative risk. If you want to know your thoughts of yesterday, observe your body today, because your body is the expression of your thoughts of yesterday and of today. If you want to know what you will be like tomorrow, observe your thoughts of today. This is wisdom. So in conclusion, don't focus only on drugs and technology, but focus on patients who should become much more aware, such as the doctors, to take care of their psychological resilience, awareness, and not just again on the basing everything on technology and drugs. So we need to talk to the doctors, because it's time to have a higher degree of awareness in health professionals if we want to have a more patient-centered approach to chronic degenerative diseases and to aging. And if we want to have a consequent socioeconomic sustainability of their management. Thank you very much. And we have to keep in mind that let's say, need to change medicine. And we are doctors. It's our turn to change medicine. Thank you.
All right, then. So thank you very much. That was a very extensive and a very interesting talk. So I'd like to review a couple of things. You had mentioned that the life expectancy in Italy now is 83. It's about 77 over here. I always talk
For
about,
women, 83, men around 82.
yeah, it's always a little bit more in women. And I always talk about the five pillars of a lifestyle medicine, which is nutrition, exercise, stress, sleep, social connections and relationship. And you have a blue zone in Italy, Sardinia, right?
Yeah, yeah.
Um,
It is called a blue zone. And if I may argue one thing, if you look at all the blue zones, Okinawa, Loma Linda, and so on and so on, they were telling they eat well, they were telling they move, and so on and so on. But that's not properly true. If you look at those people in those zones, they have resilience. They are exactly as we should be. So more than eating well in Sardinia, for example, because they eat, let's say, normally, more than moving, they move normally. More than all this, when you go that part of Sardinia, you talk to them, they feel they control the stress. They feel quiet facing any stress. That's the secret. More than eating, more than moving, more than sleeping. Sleeping is very important. Again, the chronic stress management is probably the core issue.
yeah, we have a paradox in the United States. We spend more money per capita than any other country, but we don't have very good health. We have a lot of chronic diseases. 70% of Americans are either overweight or obese. So are you saying that Americans are less resilient? Is that the reason that Americans live
Well,
shorter?
on on one hand, I guess the stress, chronic stress is quite widespread, let's say in USA probably, but it could be a matter of resilience, of awareness. And I didn't talk because that was not my topic about the importance of the first 1,000 days of life during pregnancy and during 2, 3 years of life. During that period, we receive a priming from our parents, from our grandparents, from our babysitter, whatever. That priming gives us the way, gives us, let's say, the way we handle stress, we cope with stress. So probably in USA there could be a different situation as to those first 1,000 days of life, because resilience come from there. And probably there could be, let's say, a different situation. But Italy is not so good. Okay, we live longer, a little bit longer, but not as long as we could live. Because with proper resilience, the blue zone or whatever, you could live nowadays quite easily 110, 120 years. Because if properly manage stress, sleep well, and also eat well and so on, you can really prolong life without that amount of drugs. Because in Italy, another problem we have, maybe in USA as well, the vast majority of my patients are to 10 drugs.
I think also in Italy, you hit the mark more. I mean, in terms of nutrition, exercise, stress, sleep, and social connections, I think it's all better in Italy. Food in America, is mostly highly processed. I mean, the food in Italy is much better, obviously. Like most European countries, you do more natural exercise, more walking, just functional exercises. Europeans are more active. And I think you have less stress over there in other countries in Europe. Most people in America do not get adequate sleep, and America's become less family orientated. It's more, individualistic, and
Yeah,
a lot of countries
that's
outside,
important. Yeah.
yeah, they have more family connections. So I think on those five, you really hit the mark better. So let's talk about, you spend a lot of time talking about the quality of scientific publications, and I would agree with you completely. The quality of a lot of publications is not good. One thing about them is you only have to show that a treatment, an active treatment, is better than nothing. There aren't many active comparators, so they're all placebo controlled, and something's better than nothing is not it's pretty low bar, and then you've got publication bias. Only positive results are published. Also, what do you think about resveratrol?
Resveratrol is one of the, let's say, promising molecules we have from nature. Okay. More generally, I would say polyphenol. And I personally love a lot of polyphenols for my patients. And there are some hydroxytyrosol, maqui, curcumin, for example. Resveratrol is one of those. If we go to this kind of molecules, if I may say my personal opinion, I love melatonin. Melatonin, having said that chronic stress management is fundamental, vagal activation is fundamental, then melatonin is made for that on
Yeah.
one side. Then we have, for example, other possible interesting molecules targeting mitochondria, PQQ, coenzyme Q10. These are helping mitochondria function, which is, in my humble opinion, again, of extreme importance to human health. Then we may have other molecules such as procaine, which is probably the best regulator of the autonomic nervous system, again, entering the whole neurovegetative system activity, for example. We can have other molecules, but okay, we know that supplements may play a role, they do play a role, but probably the most important could be melatonin.
Yeah. People don't realize that melatonin and vitamin D or hormones are very important. Most people in the United States, I think 70% are vitamin D deficient. So, yeah, it's important to balance these hormones. So I'm glad you mentioned both of those. I think there's quite a bit of evidence that those are beneficial. I mean, there's nothing proven in terms of anti-aging, but if you improve the health, they're obviously going to live longer. So I think there are many things that can increase longevity, but we don't have anything anti-aging right now. But I'm sure that will be round the corner. And as you know, the number one risk factor for chronic disease is aging. So if we can reduce that, I think, in terms of, I mean, you look at some of these old patients, old people, 90 and 100, they're not in very good condition often. They're very frail, and you've probably read a lot about sarcopenia. And if we can maintain a good amount of muscle, both in volume and function, I think that's very important. Frailty is a diagnosis where you can see these individuals, they have very little muscle, very skinny arms, stooped posture, wide gait. And, we really don't want to be like that. So I think maintaining muscle mass is going to be very important. You mentioned GLP-1 inhibitors. There's a lot of focus on that. All I would say is that for a lot of these drugs, it's a risk benefit. So I think the benefit of losing weight, in my opinion, outweighs the risk factors. I mean, I treat a lot of patients with these drugs. The main side effect is nausea, which is transient. So it does have a fairly high incidence of nausea, but I haven't seen any serious side effects. And then you made the point that when you stop them, the weight can come back. But it's the same as diets. They don't work unless you change your lifestyle. But, at least it gives you a kickstart. But if you don't look at your nutrition, exercise, stress, sleep, the weight will come back. But there are ways to mitigate that. But personally, I feel it's a good drug. But we'll see. There's a lot of controversy about that. Medication side effects. That was very good what you mentioned there, because a lot of what we would think as benign drugs, anti-inflammatories, they cause 16,000 deaths in the United States. So I like what you said about looking at side effects. When we think about drugs generally, the most important thing is safety. A drug could be very effective, but if it has a lot of death, that wouldn't be good. Efficacy, I say the bar is pretty low. It's got to be better than placebo. And then what we have over here is TV advertising. You don't have that in Italy. I don't think it's done in any part of Europe.
No, not yet. If I can say just one thing, I can accept drug administration. I'm not against drugs, of course, doctor,
Yeah.
but I try to patient responsible. That's the issue. I don't want the patient depends on drugs or technology. I say you can take some drugs when it is necessary, but you have to change your life. I suggest you something. If you want, you can change your life because I cannot heal you. This is what I tell my patient. I can help you with your healing process. If they get to the shortcut, typical situation with diabetes, I give you an example. The patient comes and he has just for example 6 point measurement you have in USA. Anyway, 7 is pathologic, okay, in Italy. And they take 40 units of insulin, come back and they have 7.2 and they give more insulin. I'm against that. I say, no, you have to change your life. You don't need more insulin. You need more walking. You need a better nutrition. So it's a matter of responsibility. If we do not involve patients in the treatment and just give more drugs, things will never work, I think.
No, I don't think so. And most people, they don't want to do lifestyle changes. They want medications and surgery. So a lot of physicians I've spoken to, they've said that, once they've got into this subject and they've done a lot of reading, and their health improves because based on their studies that they make some changes. So have you found that since you've got into longevity, you've made some changes? And if so, what are those changes?
Well, the very first one was intermittent fasting. I
Right.
started 6 years ago, and every single day I am on intermittent fasting. 16 hours, 17 hours a day, I do not eat.
Yeah.
Unfortunately, I skip breakfast. I should skip dinner, but as a medical doctor, I work like hell from morning to evening, and when I go back home, it's quite difficult not to eat, to make it simple. Okay. So anyway, I skip all times my breakfast. So I have no meal for about 16 to 17 hours on one side. Then I take some supplements, melatonin first of all. I take some vitamin C and mitochondria targeted supplements because I do think mitochondria are very important. Let's say I do not exercise so much. I should exercise more. That's my pity. Let's say my main problem. I should improve. But on the other side, I have significantly improved my resilience. I did all my best, let's say, to change my character, not change, but to improve my character, facing any difficulties or troubles along my life. And that gave me the possibility to reduce, of course, cortisol, adrenaline, noradrenaline, and so on and so on. It means you reduce the hyperinflammatory state that stress generates. And when you reduce chronic low-grade inflammation in your cells, you are basically reducing aging. You are slowing cell senescence, to make it simple.
Well, you know what? I think you're working too hard. So thank you very much.
You're welcome, Noor, and I hope I did my work good because in English it's not easy to talk about such a complex thing.
No,
I
that
will
was that
improve
was
in English.
that was very good, and I want to really thank you. It's good to get perspective from people outside of the United States. All right, so again, thank you very much, and have a good evening. Please subscribe to my channel and read my new book, 100 Pathways to Longevity: Add 25 Years to Your Life, available on Amazon.